I'm Dr. Takacs. It's my honor to introduce Dr. Takacs. So, Dr. Danielle Takacs is an assistant professor with the Neurology Department and Section of Neurophysiology and Epilepsy at Baylor College of Medicine, Texas Children's Hospital. So, she's a graduate of the University of Texas Medical Branch, School of Medicine, and went on to do her child neurology training at Baylor, where she served as chief resident and subsequently completed a clinical neurophysiology fellowship. So we were co-fellow together. Her areas of clinical focus and research include neonatal seizures, epileptic encephalopathies, childhood epilepsies, and particularly epileptic spasms. She is the co-director of Epileptic Spasms program at Texas Children's. She is a member of Alpha Omega Alpha Honor Society and the Gold Humanism Honor Society, and numerous additional professional organizations. So she has been honored with teaching awards and holds active membership in multiple professional societies, including the AAP, AAN, ACNS, AES, CNS, and others. So today she will speak about the diagnosis and management of epileptic spasms. So I would appreciate if you can leave your question to the end for the clarity of presentation. So thanks so much, and please welcome Dr. Takacs. So Danielle, go ahead, please.
Thank you so much, Dr. Takacs. It's nice to be with you guys here this morning via the internet. And I appreciate the invitation to come and talk about what is kind of my passion project within child neurology and epilepsy, which is epileptic spasms. I've put the CME code here, some places in the beginning, the middle, and the end of the presentation for those of you who need to sign in order to obtain CME credit. As Dr. Takacs mentioned, I'm one of the faculty over at Texas Children's in Houston, Texas, and we miss Dr. Takacs, but we hope that you guys are enjoying him over at Louisville. So as far as disclosures, I have no financial relationships with commercial interests, but I have, and I always like to appreciate the Texas Neurologic Society for this, been given a small grant through this nonprofit organization. To review the learning objectives, I want you guys to be able to be exposed to the clinical presentation, diagnostic workup, and management of spasms. And I'll use epileptic spasms and infantile spasms somewhat interchangeably. The most part of these spasms do occur in the infant period, but there, of course, are instances which they occur greater than the infantile period. We'll review the evidence-based guidelines for standardized treatment, and we'll discuss the rationale for the development of a comprehensive spasms program at Texas Children's, a tertiary care center. By the end of the presentation, I'm hoping that you guys will be able to better recognize movements and clinical symptoms concerning for spasms, identify aspects for diagnosis and etiological investigations, apply evidence-based guidelines, or at least the literature that we have so far, for standardized treatments of spasms, and to recognize the developmental consequences of untreated spasms, the general prognosis of patients with spasms, and their outcomes. So as a basic introduction, we can't ever talk about epileptic spasms or infantile spasms without bringing up West syndrome, right? It was described by West in 1841, and it's a triad that consists of 1, epileptic spasms, 2, hypsarrythmia, which is a pattern I will discuss, and 3, psychomotor delay or developmental delays or arrest in developmental progress. So some people may be wondering, why focus on epileptic spasms? It sounds somewhat innocuous, right? It doesn't sound too concerning, but actually this is kind of the most common cause of infantile epilepsy, especially infantile epileptic encephalopathies in the world. It's a somewhat common condition for an overall rare condition, affecting 2 to 3 per 10,000 children, with a peak incidence that occurs around 4 to 7 months of age, obviously a very important time developmentally for children. There are very frequent delays in diagnosis. The spasms are often mistaken for normal baby movements, which leads to delay in treatments. For example, just this past week, I had a pediatrician that I was speaking with about one of her patients. She's been in the practice for over 40 years, and she literally said to me, I didn't know we had treatments for these now. So for me, education is a huge part of what I hope to achieve through the Epileptic Spasms program and through kind of the general public service announcements that I'm hoping to help to further, at least in my area, and ideally, work with national organizations. There's often been, in the history of spasms treatment, a lack of standardized and evidence-based treatment practices and protocols. the use of traditional anti-seizure medicines has time and time been showed to have not good outcomes or not good efficacy at controlling spasms and the abnormal background pattern of hypsarrhythmia. Yet they continue to be used pretty frequently, sometimes because of just familiarity with those medications as opposed to the medications I'll talk about in this presentation that are better suited for treating spasms. Certainly, developmental delays are seen in children who have untreated or delay in treatment of spasms, which are potentially avoidable. Education is key, and very importantly, support staff is key in order to successfully achieve timely medication initiation. So what do? I start this epileptic spasms program, as I've alluded to streamline the treatment, especially at our large institution, and to add to the clinical data. So the goals of our epileptic spasms program was to establish a comprehensive program and one that can provide clear goals for therapy as well as evaluation of these patients. The formal program was just started this past July. So of course, in the midst of a COVID pandemic, that was interesting. And the main physicians are myself and Dr. Asht Katian, and our nurse coordinator and administrative support contact is Carrie Vanderslice, without whom I don't think we would be able to have very much success in kind of holding everything together. The goals of the program were to establish standardized evaluation and treatment protocols across our hospital system, to provide regular trainee and, honestly, departmental education about the best practices, and the development of a patient registry, and for which we have an IRB in place, in order to look at patient groups, treatment outcomes, and also to provide educational seminars and participation in national and international data sets. And finally, to evaluate and manage refractory cases, both from within our epilepsy center and from other institutions that need to have a second opinion as far as management. So as far as the educational aspects so far of the program, we've developed these protocols, as I've mentioned, which we'll go through. We also have held specific educational seminars, a spasms educational series, including 4 separate lectures on the basics and treatment of spasms, EEG characterization, focusing more on the neurophysiologic aspects of spasms, diagnostic workup of spasms etiology, which is important, especially when it comes to treatment and management, as well as prognosis. And then we additionally had a specific session focused on the logistics within our specific institution of ordering and scheduling epilepsy monitoring unit studies, as well as the specialty medications, because each of these medications, particularly ACTH and vigabatrin, both require specialty enrollment forms, communication with their specific medication hubs. And thanks to our excellent coordinator, we also have monthly refresher sessions, given that we are a training institution, a teaching institution, and we have general pediatric residents who rotate through our service, our primary neurology service, every month. And so therefore, to kind of further the education of each person that comes onto the neurology service, we have a refresher kind of going over the basics of this treatment each month. I'll talk a little bit about the future directions of the program, which I have not been able to do yet, thanks to kind of the hindrance of the pandemic. For example, I was hoping to develop some educational seminars for general pediatric practitioners. I plan to have a grand rounds within the Texas Children's Institution this year in order to discuss the importance of early recognition and urgent referral for spasms, as well as, kind of like I've mentioned before, public health awareness activities, as well as support activities for the families who have patients with diagnosis of infantile spasms or epileptic spasms, as well as continued provider and trainee education and refresher courses. And we are considering in the future kind of having a formal inpatient consultation team that actively rounds on these patients in collaboration with our ketogenic diet program, which does have formal rounds on our admitted patients, especially since ketogenic diet is often used as a treatment in refractory spasms cases. Additionally, we welcome any external referrals or telemedicine conferences or consultations within the constructs of insurance approval for cross-state line telemedicine consultations, especially for refractory cases. So let's kind of start talking about the clinical features of epileptic spasms. And I'm going to pull open a video. Let's see if I can play this straight from this PowerPoint. We've had a couple of glitches, but let's see. This is from the Tuberous Sclerosis Alliance. And so it's going to play via YouTube. Let's see if it works. I think it should. You may not be able to hear the video, the video sound, but it's just an instrumental track. So this is kind of a good educational video that I often direct pediatricians to, I often direct families to, for good examples of what infantile spasms look like. And there's tons of videos online that have good examples of infantile spasms. So as you see here, most of these spasm examples are more symmetric examples, but spasms can be asymmetric in nature. One side can be more affected than the other side. But most importantly, they're typically stereotyped. They can be flexor, extensor, or mixed axial jerks, or as this video is showing now, repeated head nods can be more subtle. Some patients just have repetitive eye rolls. And so as you could imagine, sometimes they're easily missed. But see, that's a good example in this video of kind of a striking pattern that's very repetitive, often misdiagnosed as colic, reflex, or other normal baby movements. So this video just kind of tries to bring awareness to the importance of spasm evaluation. So you have stop infantile spasms. Number one, see the signs, clusters of sudden repetitive movements that we've mentioned. Take a video, because that's the best way to kind of have a specialist evaluate. Obtain a diagnosis with EEG. And then finally, to prioritize treatment in order to minimize developmental delays if possible. And as this video says, every day delay, you increase your child's risk of brain damage. And there's a great resource here at infantilespasms.org, which I highly recommend anyone to visit if you need to give patients or families information. So infantile spasms are most commonly occurring in general upon arousal from sleep, though you certainly can have them kind of within sleep periods, maybe slight, stimulation out of sleep, as well as throughout the day, especially as they've progressed. They typically occur in clusters, especially, again, as the spasms progress, without treatment especially. And there's typically two components. You have the phasic component lasting 1 to 2 seconds, and you have the tonic component whenever the baby has stiffening of the axial sort of torso as well as arms, usually more involved than legs, but you can have both the arms and legs involved. Okay, and so looking at the ILAE, the International League Against Epilepsy, which makes me feel like a superhero whenever we talk about that, the 2017 classification of seizure types, as you can see, epileptic spasms is not limited to focal or generalized. It can be either onset and can be unknown onset. So I've just put stars demonstrating that here. And here in the superscript, you can see that degree of awareness in infantile spasms is typically not really specified, mostly because they're so short, and so the patient doesn't really have altered awareness after each individual spasm, but certainly can be fussy or cry. So the diagnostic workup for spasms, as I've already alluded to, is definitely getting that EEG study. So hypsarrythmia is kind of what you hear of as the classic background pattern, so interictal, meaning not during the seizure, but in between spasms, seizures, first described by Gibbs and Gibbs in 1952. And this is a quote from their paper out of the Atlas, or not paper, their Atlas of Electroencephalography back in 1952. Random high voltage waves and spikes, they appear to vary from moment to moment, and they originate from multiple areas, so multifocal. And occasionally they may seem generalized, but typically you don't usually get a nice rhythmic, repetitive, or highly organized pattern. That would be more in line with like Lennox-Gastaut with your slow spike and wave patterns. And so the hypsarrhythmia definition only requires 3 main tenets, right? High voltage, and typically that's considered greater than 200 microvolts whenever you measure on the EEG. Disorganized, meaning you don't have the usual during the periods of hypsarrhythmia. You don't have the usual anterior to posterior gradient, posterior dominant rhythm, and nice kind of like your normal EEG background look. And again, multifocal spikes. So spikes coming from multiple different regions is usually a requirement of diagnosis. That being said, you do have some other features of hypsarrhythmia that I want to mention, and I'll go forward with the modifications of modified hypsarrhythmia in the next slide. Most commonly, hypsarrhythmia can be seen in non-REM sleep. It's greatly reduced or maybe absent completely in REM sleep, rapid eye movement sleep. And so typically in your EEG evaluation and diagnosis, if it's not frank hypsarrhythmia, and if you have not captured the spasms of concern, you really should capture several sleep cycles to best rule out periods of hypsarrhythmia. Why? Because even if only part of an EEG, especially during sleep, demonstrates hypsarrhythmia, this meets criteria for a hypsarrhythmic EEG, okay? And often you may see this only part of an EEG meeting criteria early in the diagnosis of infantile spasms or West syndrome. And so it's important to fully evaluate these patients when possible based on institutional limitations. So this is an example, it's kind of a cartoon example of a hypsarrhythmic EEG, and you can just see that there's not really a nice kind of organized pattern. You see very spiky activity in multiple regions, and so this is kind of an example of what you'll see. Often, a lot of times, whenever you first open an EEG of a hypsarrhythmic EEG, it literally looks like a child took a black pen and scribbled all over the page. That's how disorganized it looks. This is an example of kind of the gain or the amplitude of the EEG kind of turned down, so you can kind of see the full line. But there are 5 variants of hypsarrhythmia. This is not new. This was first published in 1984 by Drs. Rockaby, Frost, and Kellaway, who we were lucky to have at Baylor. And so the 5 variants here specified are hypsarrhythmia with periods of increased interhemispheric synchronization. So that's kind of like the generalized sort of appearance that can come and go, which is the most common variant. But still, it meets the criteria of very high amplitude, multifocal spikes, and disorganization at times. 2, asymmetrical hypsarrhythmia, so can involve one side more than the other. Hypsarrhythmia with a consistent focus of abnormal discharge. So within the multifocal spikes, there can be one specific area that is most prominent. Hypsarrhythmia with episodes of attenuation, and I believe this typically means you have the areas of attenuation, but it's not necessarily associated with the clear clinical spasm. We'll talk about what spasms look like on EEG shortly. And finally, hypsarrhythmia comprising primarily high voltage slow activity with a paucity of sharp or spike wave activity. This being said, it should be important to know that modified hypsarrhythmia, so any of these 5 variants, does not have a better prognosis than your classical hypsarrhythmia. So it's still considered to have the same sort of concern for developmental arrest or developmental delays in the future, if untreated, especially. So as far as ICTAL EEG features, so looking at during a spasm, there's typically 3 main components. So you have a high amplitude slow wave, medium to high amplitude slow wave, followed by diffuse flattening of the EEG or electrodecrement. You'll often see it described in the EEG reports, with often overriding low amplitude fast activity. But there are 11 combinations possible, which I won't go through, but this is, if you like the resource, it's in this 1979 article, again by Drs. Kellaway, Rockaby, and Frost, and also Zion. So this is a little bit blurry, and I apologize, but this is kind of comparing the normal awake EEG, very organized looking background, to your infantile spasms. And you can see here, you have the hypsarrhythmia kind of proceeding on the left side of that infantile spasms example. And you kind of see an abrupt change, right? You see a large amplitude, moderate to high amplitude slow wave, followed by like a dampening of the activity with that fast activity, kind of looks like a buzz overriding. And this period here is whenever the spasm clinically would occur. So the next important thing to look at, you diagnose spasms based on EEG, and the next important thing to look at is what has caused the spasms. And we typically put these patients in 2 main camps based on what our evaluations show. So symptomatic, spasms, or those with some sort of identified underlying etiology, account for 60 to 70% of the cases, based on the different papers that are available, compared to cryptogenic or unknown cause spasms, which usually account from anywhere from 10 to 40%. So you see there's a wide range. There's certainly, we have more and more underlying causes, metabolic, genetic, structural causes that we identify over time. And so that's why you kind of see a wide range of cryptogenic, for example. And so I'll just give you a brief example. So here you can see that there's tons and tons of potential underlying causes of spasms. And I won't go into these in particular. That would take probably weeks to kind of go through. But here's a great article, Infantile Spasms U.S. Consensus Report, if you have further interest in looking into, the overall report. That was from 2010. So this brings me to an example protocol. It happens to be my protocol for the diagnosis and workup of epileptic spasms. And as we've discussed, the most important initial step is to confirm the diagnosis with video EEG. As you see here, I've mentioned it often requires an overnight video EEG, or at least a prolonged EEG, when capable or when possible within institutions. And then we typically also perform a pyridoxine challenge, as is recommended for most new onset seizures in patients under the age of 2, for example, in order to identify pyridoxine-dependent seizures, pyridoxine responsive epilepsy, with the caveat that you may not see response immediately on the EEG. Sometimes you do, but that is more the exception rather than the rule. And so often we will initiate pyridoxine treatment while we wait for the confirmatory studies to come back, which I'm going to discuss shortly. And so once you've done those two things, the next step is typically to get brain imaging, right? Because one of the most common causes of epileptic spasms is tuberous sclerosis. And certainly the MRI will come back showing tubers or not tubers, or other cortical malformations and other signs of, for example, hypoxic ischemic injury that can give a pretty straightforward etiology for the spasms onset. And then the next sort of step, or really concurrent step with the further evaluation after you've confirmed a diagnosis of spasms or hypsarrhythmia, is to get your laboratory work. And this includes tons of different things, but I would like to at least, at minimum, make sure that the patients have your basic metabolic studies. So you want to rule out problems associated with, your organic acidemias, your non-ketotic hyperglycemia. And things, you need to definitely get a lactate, ammonia, your basic blood count, comprehensive metabolic panel, your basic studies that you do for many patients who present with seizures, whether infantile or older. And there is, I tried to get this on each patient, a free epilepsy gene panel. It's sponsored by certain commercial interests, but I'm not going to mention the exact sort of website that you use. Speak to your friendly epileptologist, or many of the general neurologists also will, of course, know about this panel. But this is free for patients less than 8 years of age. And then finally, there are certain lab groups that will do a neonatal seizure panel testing for treatable conditions. And this usually includes both blood, CSF, and urine testing. For example, looking at your amino acids, your urine organic acids, acylcarnitine profile, as well as the vitamin B6, the pyridoxine-dependent epilepsy labs, the AASA and pipicolic acid are examples of those, as well as, and I misspelled guanetoacetate, my apologies, your creatine, guanetoacetate, your biotinidase, and your urine purines and pyrimidines. So these are all causes that are thought to be easily treatable if they're diagnosed early and managed appropriately. And again, there are certain labs that have such panels, but I'm not going to mention specific ones today during this presentation. So of course, 2020 was a year of obstacles, and 2021 has had its fair share so far. We in Texas have had this kind of crazy winter storm in the last 2 weeks, which prevented a lot of my patients who were supposed to get their follow-up EEG from coming in, or has prevented literally the start dates for some of the medications, because literally the trucks were not able to go out and do deliveries because we don't know how to drive on ice here in Texas. But in early 2020, early in the pandemic, the Child Neurology Society did put out some kind of modifications to the recommendations for infantile spasm management and evaluation. So certainly in the beginning, when we weren't sure about kind of how the pandemic was going to be shaping up, they recommended to minimize in-person healthcare visits, which we took to heart. We mostly did all of our visits for spasms patients via telemedicine. And it was very key to get a home video that captures the spasms. And after review, kind of we would look at whether we felt like treatment was warranted based on kind of the clinical presentation, which is not our typical way of doing things, but EEG confirmation was strongly encouraged to obtain at least one sleep cycle. And at that time, outpatient EEG was preferred over inpatient admission. And follow-up EEG, so the CNS recommended that if parents reported that clinical spasms were continuing, that you should add or modify treatment without a confirmatory EEG. Again, this is during pandemic times. Whereas if the clinical spasms were reported to be resolved, or if the caregiver was uncertain, a repeat EEG was advised, including at least one sleep cycle. And during the pandemic height, again, outpatient EEG was felt to be more safe for patient and for techs, for example, over inpatient admission. These make sense in the context of the pandemic, but I'm going to show you quickly some data that I've collected over the past year. And I've actually had more patients to add to this cohort since this was presented at the American Epilepsy Society meeting, virtually, of course, in December. And essentially, certainly in the past, going back to the times of Rockaby and Frost and Kellaway, there have been underreporting of spasms, especially whenever it comes to follow-up studies by parents whenever they're on treatment. They see a significant reduction in the spasms. They think, my child is not having spasms anymore. And time again, we've proved that actually they're just more subtle, and so you're not recognizing them. So there's been significant data put out on that as far as like parents under recognizing spasms. However, I'll bring your attention to this chart within my poster that's soon hopefully going to be published as a manuscript with the additional patients. You can see that these highlighted no examples are examples of when parents had actually said, my patient, my child is still having spasms despite the 2-week therapy with appropriately chosen medications. And at least 3 patients out of, 3 patients out of, I believe, out of 28, that patients supposedly had continuation of spasms. We were able to capture those events of concern on EEG with an overnight EEG and demonstrate that they actually were not spasms. So this kind of has led to our development of essentially the recommendation to do at least an extended EEG at that 2-week follow-up mark so that we don't further increase treatment as the CNS, if I go back, has recommended here. If spasms continue, you're going to add or modify treatment, right? Well, what if those events are actually those normal baby movements that are sometimes difficult to, are often confused with spasms? So this highlights the importance of the objective continuous EEG or extended EEG at the 2-week mark, specifically for our institution. And we are lucky, and I will admit that I feel very fortunate to be at an institution where we have significant electrographic monitoring resources. And I certainly understand that not all institutions are privy to those resources. So for our institution at Texas Children's, from April to July, we utilized mostly the outpatient EEGs, 2 to 3 hour EEGs, to reduce the 24-hour admissions, both for diagnosis and for follow-up in many instances. And this was especially true while we were on kind of hospital shutdown mode or reducing any elective procedures, surgeries, admissions. However, over the course of the summer, we transitioned back to reopening our EMU, both for our characterization studies, our surgical planning studies, and our spasms diagnosis and follow-up patients. So all the EMU admits get a COVID-19 test 2 to 3 days prior to admission. And so it's been our practice this year that any fever, illness symptoms, or positive results result in deferring that hospital admission. And so we then do fall back on treating based on parental report, because we don't want to increase our exposure for our techs, for our medical staff, and for our other patients at the hospital to a COVID positive individual. So the last treatment guideline that was put out by the American Academy of Neurology was last done in 2012. And as you can see here, really the only sort of level B at maximum evidence at that time was considered to be TCH. And at that time, they actually said low-dose TCH can be considered as an alternative to high-dose TCH for treatment of spasms, ACTH for treatment of spasms. I believe that was mostly due to safety profile and side effect profile. But there have been a lot of papers put out since this time. We just haven't seen the actual finalized new recommendations come out. So I'm going to kind of go through some of that evidence and papers now. Not exhaustive, but hopefully we can kind of agree that there need to be some changes to this guideline. So the first kind of major study that was put out that I'm going to talk about was the UKISS study, the United Kingdom Infantile Spasm Study, that was put out in Lancet in 2004, the first kind of mutterings about this. And so this study compared using vigabatrin with a hormonal-based therapy, that is either oral prednisolone or the intramuscular ACTH, or tetracoxactide, which is the European version of ACTH. It's important to note here that the prednisolone dose used was not a weight-based dose. It was a 10 milligram 4 times a day start, and then a taper thereafter for you do the 10 milligrams 4 times a day times 2 weeks. And so in general, kind of the two comparison arms, you had 55 patients in the hormonal group compared to 52 patients in the vigabatrin group. Again, not super big numbers, so we have to take everything with a grain of salt. But we saw 73% overall reduction in the hormonal treatment group compared to just a 54% spasm freedom or hypsarrythmia freedom at the 14-day mark of therapy in the vigabatrin group. And you can see the breakdown between ACTH and prednisolone there, but the study was not powered to compare between those two hormonal groups. And unfortunately, you'll see that's a recurring theme. And looking at the developmental outcomes, so they use something called the Vineland Adaptive Behavioral Scales. I'll refer to it as VABS. And so again, this is the same UKISS study. The main developmental score, this behavioral scale, did not significantly differ between the two groups at 14 months. However, infants with cryptogenic spasms, so those that we don't have a clear underlying cause for the spasms, their mean VABS scores were higher in the hormonal arm of therapy compared to the vigabatrin arm. Then here is an example of that same UKISS trial that looked at developmental and epilepsy outcomes at 4 years. Again, using the VABS score, and then the epilepsy severity was actually used, was actually evaluated via questionnaire. And they did not find major significant difference in general between, again, the hormonal and vigabatrin groups, but the cryptogenic spasms, once again, the VABS scores were higher in the hormonal treatment group compared to vigabatrin. So the summarized findings essentially are this. Early seizure control is important, and I'll talk a little bit more about that towards the end of the presentation. But development at 14 months was better in the cryptogenic group and at 4 years in the cryptogenic group if steroids were used over vigabatrin. This is a more recent study in the Annals of Neurology in 2016 by Dr. Nupp et al., showing that a little bit different sort of outcomes, showing that there was maybe a trend in favor of ACTH. Granted, this is high-dose ACTH that's used, so 150 units per meter square total per day divided twice daily. And again, kind of using just that non-weight-based dose of the prednisolone, the 10 milligram 4 times a day. And as I wrote in a couple of slides ago, that is 8 milligram per kilogram per day if the patient is 5 kilos. But many of these patients are not just a 5 kilo baby. This can present up to age 2 years of age often. And so you'll definitely be on a lower milligram per kilogram dosage. per day if you just go with the standard set milligram treatment per day. So this is not really evaluating a weight-based high-dose prednisolone. And so again, you can see that the hormonal therapies in general are considered to be more effective at eliminating spasms and hypsarrhythmia at that 14-day mark compared to vigabatrin, though here you kind of see a trend more in favor of ACTH, certainly. Again, this one had a better enrollment, so we had 230 patients as opposed to like half of that in the UKISS study. And this is one of the few studies that we have kind of looking at actual high-dose prednisolone, again, not a weight-based dose, but up to 60 milligrams per day versus moderate dose. This was SACTH, but essentially this is giving ACTH on alternating days. So a little bit different protocol, but this one showed prednisolone with far better resolution of spasms and hypsarrhythmia compared to ACTH. So all in all, what I want to drive home is that there hasn't really been a good randomized controlled prospective trial comparing high-dose ACTH to high-dose prednisolone. There was a 2016 study by Knupp et al. In the Annals of Neurology looking at the 40 to 60 milligrams of prednisone compared to the 150 unit per meter squared of ACTH, and they found that actually, and I didn't include it in the slide set, but they found that there was a statistically insignificant difference between the outcomes of spasms between ACTH and that high-dose prednisolone. But I think we really need a large multi-center trial to look at the high-dose prednisolone because, especially as you see here, the cost comparison is stark. You're at two major ends of the spectrum, right? Prednisolone is quickly available, very inexpensive, whereas ACTH, there's so many medication delays. If it weren't for our nurse coordinator, Carrie, who's had to at times have at least 10 phone conversations per day with the medication hub, especially for ACTH, communicating back and forth with him for up to 5 days at a time. And that includes like where the medication is going to be delivered, which pharmacy it's going to be filled through. And I will also say that I have seen increased side effects in ACTH compared to prednisolone as well, whenever patients are on that therapy. But overall, kind of the take-home point from the evidence I want you to take away is that hormonal therapy seems to be superior to vigabatrin, with one exception, whenever you have a diagnosis of tuberous sclerosis, which that's well documented in the literature, that that's the first-line therapy for patients with tuberous sclerosis. And actually, there is currently an actively recruiting trial for patients with diagnosed tuberous sclerosis that uses vigabatrin before seizures or spasms even present. So it's a preventative trial that's ongoing right now. And you can look at, if you're interested in that you can go to the infantilespasms.org and look at the research tab. So there has been the most recent sort of consortium is the ICTAL, with a C this time. So it's the International Collaborative Infantile Spasm Study, which has started putting out some literature starting in 2017. That started looking at what about dual therapy for the first line. So this is comparing hormonal therapy, either the ACTH or the prednisolone, compared to a dual therapy with both one of those hormonals plus vigabatrin. And as you can see here, like it seems that the dual therapy has improvement in the spasm freedom and hypsarrhythmia freedom from 14 to all the way to 42 days. So certainly over that 2-week sort of mark, compared to the hormonal treatment only. That being said, there are barriers to using dual therapy because of cost, insurance approval, side effect profile, certainly we'll talk about that. And also of note, in follow-up studies, there was no significant developmental or epilepsy outcome differences between the dual therapy group or the hormonal therapy only group at 18 months. Of course, studies are still ongoing to kind of look into this, but that's just one thing that I wanted to mention, this new ICTAL randomized multi-center open label trial. So here's our treatment protocol at Texas Children's whenever it comes to the initial therapy. So we have not yet adopted dual therapy from the onset, mostly because we're taking baby steps. And so as you see here, you have two main arms, right? You have the tuberous sclerosis known diagnosis, which you would start vigabatrin, and then you have the non-tuberous sclerosis side. And you would start some sort of hormonal therapy, a steroid, ACTH, or prednisolone. And we use the standard 150 international units per meter squared per day over 2 weeks, divided BID, or the prednisolone 8 milligram per kilogram per day. So we do a weight-based dosing, divided 3 times a day or 4 times a day for 2 weeks, max 60 milligrams per day. And with that, with either one of these two treatment arms, you're going to want to do a follow-up EEG at the 2-week mark. Now, again, we've talked about ACTH. You've got the cost consideration. You've got the time to actually initiate the medication because of delays in insurance approval, delays in medication delivery, multiple phone conversations back and forth, and multiple needs for documentation, paperwork. Whereas prednisolone is easy to prescribe, but there's still kind of the jury is out on whether it's overtly equal in efficacy. But we feel like it's probably at least reasonably comparable efficacy to ACTH. And again, I'll say that I see less side effects with prednisolone in general compared to ACTH. And obviously we know vigabatrin for TSC. So both of these arms, like I said, need a repeat study at 2 weeks of therapy, roundabout. We usually say sometime between 10 days of therapy to day 18, at which point they've already started weaning the hormonal therapy. The vigabatrin we usually at least treat for 3 months, if not 6 months. And you can see that in this protocol here, continuing the vigabatrin for 6 months. All right. And this is kind of what I've developed since I've started as faculty and even within my fellowship, the dual treatment protocol for that 2-week mark, if they're still having, if they're still having spasms at the 2-week mark after appropriately chosen therapy, then we will go on to do dual therapy. So no to treatment success if they did not have significantly intolerable side effects on hormonal therapy and the first hormonal therapy was oral prednisolone. We will stop that, switch them to ACTH since there have been some studies showing ACTH with superior efficacy, and we'll add the vigabatrin. Whereas if the side effects were not tolerable, we will usually just start the vigabatrin at that time, especially if they're having hypertensive urgency, if they're having significant problems as far as hyperglycemia, or parents are like at their wits' end and they cannot get any sleep or, cannot stand how miserable their child is. Parents are not going to give a medication that they feel like is overall harmful to their child, despite some of our, evidence based on the studies we have. So side effects, like I'm talking about, we talked about steroids. They can have irritability, weight gain, hypertension, hyperglycemia. And so I've worked with our renal and endocrine colleagues specifically to kind of set up what are our thresholds, that we would require either emergent evaluation in the ER or urgent consultation with renal clinic, hypertension clinic to be able to get medications on board for these patients. In general, endocrine says that, your risk of hypoglycemia in these patients compared to hyperglycemia is much more concerning. So they typically don't recommend starting insulin in general, but certainly we have our colleagues to call in those departments if we need. As far as vigabatrin, you have to talk about the big black box warning, right? So that there's potential irreversible peripheral vision loss risk. So we still hold the every 3-month ophthalmology visits as a recommendation. And there have been more recent sort of monitoring studies that show lower percentages compared to these that I've listed here. Certainly there's a higher risk in adults, but certainly there's a higher risk with prolonged treatment and with very high doses. So only 9% of children treated less than 12 months at maximum in the studies that I've seen so far have developed this side effect. Usually we talk about this with the parents, and especially in the patients who have significant cortical, vision impairment. This is less of a concern, the peripheral vision loss. To my knowledge, there's been no reports of any central vision loss. And of course, you can also have MRI-related changes in response to vigabatrin. These are reversible, however, and so you usually get T2 hyperintensities, restricted diffusion in the deep sort of brain regions, brainstem, and the cerebellar dentate nuclei. But again, these are reversible with reduction or elimination of vigabatrin. So in general, I don't keep patients on this medication more than 6 months unless there's been significant developmental improvement, and if the parents are willing to accept that risk kind of with the more longer term treatment, up to 12 months of that peripheral vision effect, which again is more so in my patients who have severe developmental underlying conditions or cortical visual impairment. So overall, kind of just talking about overall patients with epileptic spasms, back in the early part of the study, I mentioned that up to 70% of patients with epileptic spasms have some sort of underlying known etiologic cause, genetic, metabolic, structural. So it kind of makes sense that up to 80% of patients who have had a history of spasms are going to have some form of intellectual disability, right? Cryptogenic patients, on the other hand, that tend to up to maybe 40% of patients, and I think that's very generous, have the best potential prognosis and can have a normal developmental outcome. 94% of patients, up to 94% of patients in the literature, continue with active epilepsy after even spasms are resolved. And 15% to 20% of patients with history of epileptic spasms go on to progress to Lennox-Gastaut syndrome, which is a intractable, very difficult to treat, multi-type of seizure sort of syndrome. And of course, there's also a high risk of autism, which comes with a lot of the intellectual disability and developmental effects that can come from essentially a chaotic brain wave pattern, right? And multiple frequent seizures that we see in some of these patients. There is an important trend that was noticed in that United Kingdom infantile spasms group, in that when there are delays in treatment, should be a space there, greater than 7 days, there's a 3.9 point reduction in that VAB score, that behavioral score, associated with each sequential interval delay of therapy as follows. So if the therapy is delayed more than 7 days, up to 14 days, a 3.9 point reduction in that development score. If 2 to 4 weeks, another 3.9 reduction. 4 to 8 weeks, yet another 3.9 reduction. Greater than 8 weeks. So again, this is a 16 point reduction in that score if the therapy is delayed from onset or diagnosis to actual start of medication, appropriately chosen medication, if the patient is delayed just 8 weeks. That's why we consider infantile spasms, I call it an urgency. I don't call it always an emergency, because I'm like, it's okay if they come to the hospital in 2 days, but not in 2 weeks, right? So the takeaway point from this entire presentation that I'm hoping that I have conveyed to you all is infantile spasms, right? We need to treat early. We need to treat appropriately based on the data that we have. And I hope to add to that data in the future. Here's several resources that you can use both as caretakers in the medical field, as well as to give to your families. infantilespasms.org, epilepsy.com, and then clicking on the infantile spasms syndrome link. And then finally, healthychildren.org has a really, really great infantile spasms page for the general public as well as for pediatricians. So I hope that by the end of this talk, you're now better able to recognize the presentation and clinical symptoms of spasms, identify aspects for diagnosis and etiologic evaluations, and to apply the evidence-based literature that we have so far for standardized treatment of epileptic spasms, aka use those hormonal therapies, unless tuberous sclerosis, use vigabatrin, over traditional seizure medications for the first-line therapy, and to recognize potential developmental consequences of untreated spasms, prognosis of patients with spasms, and the variable outcomes. And finally, I hope you can appreciate why I felt the need to develop a dedicated spasms programs within our Texas Children's Institution, where we see at least one diagnosis of new onset infantile spasms per week. And so I believe my numbers are within the last year now are kind of upwards of 70 patients. And so I hope to be getting some papers out in the upcoming future, and I hope you guys will look for those, and so we can work together to best serve this patient population. And with that, I thank you guys for listening, and I'm happy to take any questions now. Hopefully I can give you the best possible answers.
Danielle, thank you so much. That was like a fantastic talk, I think. So I have two questions.
Sure.
So how do you go about like recurrence of infantile spasms? Is the treatment going to be the same? Like, are you gonna follow the same protocol? And the other question is that what is the latest age of the hypsarrhythmia or spasm that you see? What was the oldest kid that you treated?
Oh, okay. Good questions. So recurrence of infantile spasms. So it depends on where the patient is in their treatment journey at that time, right? So let's go with the easiest possible case. The best case scenario typically is you treat the patient's spasms, they're developmentally still on track, the spasms completely resolve, you're able to wean off of that hormonal therapy, right? So let's say the spasms come back in 3 months, okay? They start slowly coming back. Typically, I repeat the first treatment that I did since I know it was successful. But in some cases, especially patients that have some known underlying etiology, I will kind of do that dual treatment protocol in order to give it the 1-2 punch. There's not like the best. We don't even have the best data for the initial treatment of spasms, right? So we're still waiting on kind of outcomes with recurrence of spasms. But that's kind of been my practice. If they're completely normal developing, don't have any sort of other delays or known diagnoses, I'll either repeat that initial therapy that seemed to at least give them freedom for the several months, or I'll do the dual therapy, depending on the parent and family comfort with that dual therapy protocol, and depending on whether they had significant side effects with the previous therapies. There's a lot of things that go into it. So, on the other hand, if you have a patient, let's say, who has significant structural abnormalities of their brain structure, and they required like a second-line therapy like vigabatrin, so they're still on vigabatrin, I'll add back a steroid treatment onto their regimen to try to get control of that. And then your second question about what's kind of the oldest age that I've seen hypsarrhythmia in, I'm thinking that's been about the 2-year-old mark, and my suspicion is in those patients, most of the time they convert over to like a Lennox-Gastaut pattern by that time because their brain has just been in this chaotic pattern for so long that they kind of progress, unfortunately, on that syndrome pathway that we see, So they go from like just having spasms to West syndrome, severe developmental sort of outcomes, to Lennox-Gastaut oftentimes.
Those are steroids also?
Sorry?
Would you try steroids on those patients as well?
Yes, short term, right? You just do the high dose for 2 weeks, but typically I will recommend that we consider early vigabatrin therapy in those patients as well, because that's going to be more of a longer treatment course rather than just the 2 weeks high dose and starting to wean. And I guess your question is, do you try steroids? Your question is, do you try steroids on the 2-year-olds with hypsarrhythmia? That's your question? Yes. Yeah, I would still try it.
Okay, thank you. Any other question?
So I had a quick question. Hi, my name's Grant Turk. I'm one of the child neurology residents. And I was wondering, I know we talked about, if the patient has tuberous sclerosis, of course, we're going to go with vigabatrin as our first line. Mm-hmm. What about if they have kind of any other underlying structural abnormalities? Is there anything that pushes you more towards like the high dose steroids versus the ACTH?
Sure. Sorry, I'll let you finish.
No, that's the meat of the question.
Okay, sure. So whenever it comes to patients with clear like cortical migration abnormalities and cortical malformations, right, other than tuberous sclerosis, you already mentioned, we know we do vigabatrin in that case. I will often do the dual therapy at the onset there. And your question too, as far as whether we do ACTH versus vigabatrin, ACTH versus prednisolone, I will typically still try the prednisolone, but getting them on vigabatrin for kind of a longer treatment protocol is my go-to, but with the steroid initial treatment as well. And that's honestly mostly because of the side effect profile that I get with ACTH, and also because of a lot of the difficulties with initiating the ACTH within that 1 week sort of time frame. I do find that a lot of times these patients with cortical migration abnormalities or significant structural abnormalities who present with spasms have probably had those for more than what we've known them for. You know, like those patients typically have multiple different types of seizures. And so kind of doing the dual therapy in those selected cases, I do typically try to use prednisolone plus the vigabatrin early.
Thank you.
Yeah.
This is Lizzie Dahl. I just have a quick question about nomenclature.
Sure.
So do you prefer to call it epileptic spasms just because infantile spasms implies that the age range is infantile?
You're exactly right.
Okay. Thank you.
Yeah, so we certainly with like Down syndrome, for example, you can certainly see spasms present well outside that kind of quote unquote infant range. So that's why when it came to like naming our program, we said, let's call it epileptic spasms. Same thing with tuberous sclerosis, right? You can have spasms that the onset is far outside the infant range. So we prefer using epileptic spasms. Certainly you saw with the UKISS data and the ICTAL data, they still use the term infantile spasms. They're synonymous. It's just that epileptic spasms is more inclusive.
Okay, thanks.
Mm-hmm. Well, I appreciate you guys taking the time to listen today. Please feel free to contact me at my email here on this slide. If you have any questions, concerns, want to run a patient by us, I'm happy to help. And I appreciate your attention, everyone.
Thanks so much, Danielle, for joining us today. So thanks so much.
That's
all right,
great.
you guys.
Thank you.
I'm glad you enjoyed. Thank you, guys. Take care.
Bye-bye. Have a nice day.
Bye-bye.